Good afternoon, and welcome to another edition of SIF Virtual. And this is another edition of Interactive Case Reviews. And I'm really delighted to have our superstar panel with us, Dr. James Hermiller, Dr. Steve Yakubov, Dr. Cardlos Sanchez, my partner, Dr. Robert Burke, and our presenter today will be Dr. Mike Rinaldi. Mike, why don't you take it away?
So I'm going to show a case of a valve in valve, and it's a complex valve in valve, and I call this, I thought I knew how hard this was going to be, but I was wrong, very wrong. And so the point of this is not to show some complex fancy skills, but rather to show some difficult decision-making and clinical complexity and get, I'm not sure there is a right answer, and I'm not sure I picked the right answer, but I thought it would be interesting to show. So here's the patient. It's a 72-year-old with severe bioprosthetic aortic stenosis, and they had original a 3F valve, which is an ATS medical valve, in 2013. So I never heard of this valve, and we're going to learn about it a little bit today. So the mean gradient across the valve was 44 with a peak velocity of 4.2. The patient had dystomy with exertion in class 3 symptomatology with preserved LV function, not an elevated cardiac BNP, so kind of chronic stable on diuretics. Other comorbidities, type 2 diabetes, hypertension, paroxysmal atrial fibrillation on chronic warfarin therapy, and a little bit of mitral stenosis. EKG was an incomplete left bundle with a primary AV conduction delay, but it's sinus rhythm. Not bad kidneys, reasonable, relatively, mildly low platelets and a preserved hemoglobin. The BMI is 39, so this is a somewhat heavy patient. And her BMI has not changed since her operation. For a reoperation for this, her STS was predicted at 4%, but that wouldn't include a root enlargement. And remember, this was a relatively small 3F valve, which I'm going to go over. So other things that are important is that at 2 years after her valve implant, her mean gradient was 26, and it has crept up over the years. So the 3F valve, it falls into the category of stentless prostheses. So it doesn't actually have any type of a ring. It has a nylon ring, so it's completely flexible and collapsible, and it's almost like a freestyle valve. The other thing is that it's equine leaflets, and they're really tall. So they're 25 millimeters. So this is a 21 millimeter valve, and it's a 25 millimeter length leaflet. So very tall leaflets, and there's no frame that holds it in place. So it's almost like native leaflet tissue, but even worse. And this is not to be confused with the 3F enable valve, which is the son of this valve. This valve is the 3F valve is no longer marketed, but the Sorin 3F valve, which purchased it, I think, has a nitinol frame and is supposed to be used for sutureless implant, but this is not that same valve. And so when we look at the CT, there was moderate calcification of the right and left cusp, and some marked restriction of mobility of those two, whereas the non-coronary cusp was only mildly restricted at a perimetered area of 1.1 centimeters. So sort of moderate to moderate to severe aortic stenosis, and probably a combination of both aortic stenosis and innate patient prosthetic mismatch with a 21 millimeter valve in a BMI 39 patient. So the annulus was 338 millimeters squared in a left dominant system with a height to the left coronary, to the left main of 11 millimeters. Iliacs were enormous and easy access. So if you were going to do a TAVR in this patient, it would be either a 23 millimeter S3 valve, which would be 6% oversized, and an IEOA of 0.69, which would suggest a moderate risk of PPM. A 26 millimeter S3 valve was 34% oversized and too large, or a 26 millimeter core valve, which would be 14% oversized and have an IEOA of between 0.72 and 0.79, also some degree of PPM, probably less so. So this is a left dominant system with a virtual valve. There was 3.5 millimeters to the left main with a pretty generous sinus, but very long leaflets and a stentless prosthesis. So there was some concern, persistent, I think legitimate persistent concern for risk of coronary obstruction. And you can actually see the leaflet here. It's pretty long, and while you might get away with it, you might push it up and cover that cusp. So, what are our options? We have, valve-in-valve TAVR. So this patient was not going to get a reoperation. She didn't want a reoperation. She wasn't a good candidate for such. She could live with her symptoms, but they weren't so good, and she had significant gradient. So we thought that even though there was some degree of patient prosthetic mismatch, that doing a TAVR might get her back to square one at least, and reduce some of her symptoms. So options would be a valve-in-valve TAVR in the left, just do it, and the left main is probably going to be fine, and go for it. We weren't so happy with that option, but certainly others may think otherwise. Balloon valvuloplasty and angiography with provisional snorkel if you see evidence of obstruction. You have valve-in-valve TAVR with planned snorkel, so just do it up front. You have the option of basilica with TAVR after basilica. And
can I just interrupt 1 minute, Mike? Mike, let me just interrupt. Okay, phenomenal case, great case. I didn't expect any less. Herms, where are you starting right now?
So I think these valve-in-valves, I think are the most difficult to decide. Should we go TAVR or not? And except for BMI where it is, I would push this lady to maybe get freestyle valve root enlargement and get it done so she can get her next TAVR when she's 82 or 83. But given everything, it's understandable that she's going to be transcatheter, and in that circumstance, I think she needs to get basilica. At her age, you hate to snorkel it and sort of hope that works. We've all seen those stents get crushed in the long term. I'd basilica, and I would think about putting a self-expanding evolute in here.
Okay, Yak, planned versus provisional snorkel. Give us 30 seconds on that. What exactly is that?
The problem with this case is how tall the leaflets are in the valve. Most surgical valves are not nearly that high. And you have to worry about what the STJ measurement is on this case also, because you're definitely going to cause coronary occlusion. Even with basilica, I think you have trouble being assured that you're not going to create a problem. So if you have absolutely no surgical option, I would use an evolute, because I believe that that's the only shot you have of having as least amount of ppm as possible. And then I would definitely protect the coronaries even after basilica.
Okay, Carlos, what else?
Yeah, I agree with Steve that the 25 millimeter height of this leaflet may be an issue. There are two ways you can cause coronary obstruction with this valve, or overall. One is sinus sequestration, and the other one is direct coronary occlusion by pushing either valve or the junk. I would be very concerned for sinus sequestration here as a potential cause of coronary occlusion. But I agree with an evolute, and I agree with basilica as well.
Mike, is this one on the valve-in-valve app? You said I've never heard of this before. Is this? Do they show this on the valve-in-valve app?
Yeah, I don't think it was on the valve-in-valve app. This is a pretty uncommon valve.
Okay, all right. All right. Where was it?
Looks like a perfect valve to close off your coronaries during valve.
I agree.
I agree with that. I mean, this is bad actor.
Bob, Burke, what do you see on TEE when you're doing our TEEs beforehand, and you're going to counsel us on how to proceed? What are you looking for in transesophageal echo?
Again, you're trying to get an idea of where the commissures are going up to, where these are supported. So you're starting off with a valve that, the 3F was form follows function. So theoretically, this was going to be a very physiologic, should last forever valve. Didn't exactly work out that way. But where they have to sew in at the apex of the commissure, you've got a big flap that's going to do nothing but move backward. And the TEE might give you a sense of where that is as far as your alignment. But just what Carlos was saying is that you can close off the entire sinus with moving that big flap backward. And even with basilica, you worry because you don't have control over how that flap is going to move So you've got a lot of issues going into this from a procedural planning standpoint, both with CT or with TEE.
Okay, Mike, show us what you did, Mike.
All right. So so we actually planned Basilica, and we picked an S3 23, even though that's not what everybody else would do. And I completely understand that the concern that we had was that reaccessing the coronary with a core valve would be challenging. While we planned to do Basilica, we don't have a lot of experience with it, and we had some lack of complete trust in that, and we were concerned about needing reaccess for the coronary. So there are definitely trade-offs, and so it may have been the wrong choice, and that's why I'm showing it, because I thought it was interesting. So how do you do this? How does it work? So in the right groin, we placed a 14 French dry seal after pre-closing. In the left groin, we placed a 6 French sheath. Through the right dry seal, we placed a 7 French PAL1 catheter. So that's a specialty catheter made by Medtronic called a pachyderm. And we used that after an Amplatz left wouldn't really fit. And the pachyderm seems to be a good catheter for doing Basilica. Now, Marcus Castle was with us when we did this, and it was very helpful to have him there. Some of you know him from Germany. So placing this in the left cusp is not easy, but we'll get into that. Through that then is loaded an Estado wire through an Estado 20 through a piggyback. And a piggyback's basically like a microcatheter that insulates it. And then you scrape the back end of the Estado for contact with the electropencil for the electrocautery portion. So that's catheter A. And then catheter B is through your left sheath, and that's a 6 French multipurpose with a 20 millimeter gooseneck snare, which is then placed in the LV outflow tract, and then a V18 wire is placed parallel to that into the left ventricle, such that if the gooseneck snare comes out of the ventricle and into the aorta, you don't lose your access to the ventricle through the valve. So that's the setup, and that sounds pretty straightforward, but it's not. It takes time. So that's what that looks like. So the steps are, the goal is to place the Estado in the center of, sort of in the base or in the mid portion of the left leaflet, and then electrify it, perforating the leaflet, capture that with the snare, and then externalize it through the multipurpose, and then burn through the leaflet as both catheters are sort of gently pulled backward. And so when the Estado wire, when it is externalized, as you externalize it, you've created a V, a bend on the wire, such that the V fits right at the perforated segment of the leaflet as the sort of fulcrum for splitting the leaflet when you electrify that wire again. So you pull the piggyback back one handspan to the end of the wire and then lock it. You scrape the isolated portion and then make the V. 2 tuies are added to the ends of the wire to the catheter to keep it in place so that you have tension, and then you pull the snare and feed the wire all the way through the catheter, which is then, and use the loader to pull the snare through, and then you make your V and place that across the leaflet, and then you basically with giving some G5% through the catheters to reduce clot and char, you then electrify and pull, and that's how you basically split it, and then you move to your TAVR from there. So it appears to be hard to do, because in fact it is pretty hard. In theory, you just put your catheter at the left base and then electrify, but that's not exactly entirely how it works. Leaflet perforation should be central. You don't want to be off at one angle, but it's hard to actually put it centrally, and it's hard to even know you're central. So when we were in there, it was interesting. Castle said to us, T is not very helpful because you can't see the tip of the wire. Well, I have Marcus here who's pretty good, and you could actually see the tip of the wire. So here you see the wire is off to the edge, the posterior aspect of the left cusp leaflet, and so that's not where you want to perforate and pull through. So on the other view here, it's more in the center, still at the base, but more in the center. So that actually took some manipulation and wasn't entirely straightforward to know. And if you don't have good imaging, you might actually perforate in the wrong place and not really effectively split the leaflet. So Additionally, it's kind of hard to get the electrified wire to perforate the leaflet every time, especially if the leaflet is somewhat calcified. So here you can see our position. We're probably at the ring there. That's a little bit deep. And then you can see we're trying to electrify, and the wire is actually bending and not crossing through. And so that's now charred, and you have to get the char off. When we saw that happening, we tried to manipulate the guide a little bit more centrally off the true base of the leaflet in order to burn in a different place. And we went through a bunch of iterations of that. Eventually, we were able to cross, but then we couldn't actually snare it. It looks like it's through the snare, but when we pulled, we couldn't snare it. And I'll show this echo loop, and I'll play it a bunch of times, and maybe you can tell me, why couldn't we snare it?
Bob Burke, what are you seeing there?
Actually, it looks like you went into the across the mitral valve with that.
Yeah, so that's exactly what happened. Left atrium. You can see the wire here is on the atrial side of the mitral leaflet, and then we've made a hole through the mitral leaflet. So we went across the valve, but we went across both valves. So we actually pulled that back, and it turned out that didn't really cause significant MR, and was a mulligan. It didn't do anything bad to the patient, but certainly didn't get us where we needed to be. And I'm glad we could see that, because if we had been able to capture the wire and then burned that, we would have done simultaneous lampoon basilica, which would have been problematic.
Mike, did
Yes.
did you see the wire and the catheter clearly on the TE echo to know that you were at the middle of the leaflet before you burned?
I think we were a bit deep. We weren't as middle as we should have been.
But that shows you the problems with this type of valve, because the way the valve opens up is it does push you away as you're trying to burn.
Yep.
One big comment, Mike, a very important thing when you're doing lampoon is when you're having trouble snaring that wire and you're across, double check your wire. I think it's super important, because you probably are not where you're supposed to be. So if you're having trouble snaring the wire, if it's taking more than 2 or 3 minutes to snare that wire, start looking around and trying to find that wire.
Yep.
You're right. It goes to multiple places.
Yep. So agree. And this was, we don't have I think there are very few centers that have a ton of experience with basilica. And so this was, this is fairly early in our experience. In fact, case number 1, we had, so we positioned the wire more towards the tip, so not at the tip, but less at the base. And we were able to burn through. And so that shows one position. You can see that. And then here's us burning. So now it's through the leaflet into the ventricle. And we've now captured it and created a loop. We're pulling it up the multi-purpose, as you can see through the snare. So now here's our flying V, and we burned through a lot of bubbles, and we did not cause a lot of AI. Patient was hemodynamically stable. So here's our valve implant, 23 millimeter S3. You can see the leaflets coming pretty high up there. So fortunately, we did not have any problems with flow into the left coronary, and you can actually see it on TE here as well. You can see flow in the left main and circumflex. So success with no PVL, normal flow in the left main, and a mean gradient of 13 by TE and 24 by cath. So not ideal, but after 3 hours we hadn't killed the patient, and that's a win. And we didn't perfectly trust in our basilica, so we were a little bit concerned about post dilating. And to be quite frank, after 3 hours we were a little bit fatigued. So that's what we did. Would you have stopped there? Would you have post dilated? What would you have done?
Herms, where would you go from here on this procedure?
So first of all, it's interesting where the position is. It's a little bit lower than typical. It's more like a freestyle where you've got to be a little bit deeper. I think certainly you're not going to sequester it by expanding it. So you're not going to sequester that sinus. So you're okay there. I would post dilate it, but I sure can understand after 3 hours, we got away, she's alive. Let's see how she does. But I would.
Steve?
Yeah, I think that was the right answer.
Steve?
Yeah, I agree with you. You get fatigued. The one image that bothered me a little bit was your aortogram. It looks like you have a lot of valve balled up into the left sinus, quite a bit. I think you're pretty darn close to that coronary artery there. So you'd like to have a lower gradient. That gradient's pretty high by cath. I think if you did a surface echo, you'd probably be close to 30. Yeah, so I'm going to say, to make this case even more interesting, I'd post dilate.
Yeah, and it looks to me like, up at the top, you're well expanded, which is where it's sort of opening into the coronaries. And where the skirt is down below those coronaries. I think you're going to be all right.
Bob Burke, we have some concerns here. What's the immediate follow-up for this patient? What are your concerns, and what's the immediate follow-up for this patient, say, in the next 4 weeks?
Well, the concerns you guys have already gone over, and we're going to worry about whether or not there's going to be a role for that very redundant extra valve tissue to cause trouble down the road. But the gradient is really high to begin with. Typically, the intraop gradient is going to be lower than what you're going to find postoperatively on day one. You're always going to check the transthoracic on post-op day number 1 and reassess where you are. Look for PVL, really define what your true mean gradient is going to be at that time, and go from there. And then obviously 1 month, you'll also repeat another transthoracic echo.
Cardlos, pharmacologic therapy, anticoagulant therapy, antiplatelet therapy, what's your cocktail?
Antiplatelet therapy. We're moving away from DAPT, from DAP. More recently, there's no good data to support DAPT in this patient, so we're going for single antiplatelet therapy. And that's what I would do.
And she was on warfarin to begin with.
Yeah, would you
get
back on warfarin, Mike?
I can get back on warfarin, yeah.
Yeah. And if she wasn't on warfarin, I'd put her on warfarin.
Right. Any role for NOACs, DOACs, or we just don't have the information?
No info.
Okay. So what's next, Mike?
So post-op day 1, and at 1 month, the mean gradient was 42, and she obviously was not symptomatically improved. So the TE and even intraop, Dr. Shearer had noted that the angle was a bit off for accurate measurements, and he was not confident about that gradient. And I think measured hemodynamics in lab are sometimes lower than when the patient is awake and not under general anesthesia. So CT shows the valve to be pretty underexpanded, and obviously there was no halt too early, and she's on Coumadin. So obviously this is basically the TAVR frame is underexpanded and has an hourglass shape. And the original TAVR was also undersized for the patient, so it's kind of double patient prosthetic mismatch. So post dilation of this valve with an attempt at fracking is certainly possible. The real question we had was, would the polyester fabric ring, is it like fracturable? Will it just recoil? Will left main occlude? Will there actually be meaningful improvement if we do this? And it sounded like that everybody wanted us to go ahead and post dilate this. So still everybody agree, post dilate?
Yes.
Mike, is part of that leaflet from the original surgical valve close to the left main there? Is it partially obstructive right now?
Yeah, so I think the leaflet comes right up to there on this, as best we can see from CT. So there's a little bit there, and who knows, I don't think this shows well. I don't think CT shows well if the basilica actually split the leaflet in a way that made it curtain over the frame.
Did you try to reaccess?
There's a little bit of trust in that.
Did you try to reaccess the coronary at all?
So we didn't try to do that, and so what we did was we went for it and just post dilated it with a 23 millimeter true balloon, and you could see that frame really actually expanding further. And I'll let that play a few times.
Mike, if I can ask you, how did you decide on the 23 true?
Well, we wanted to make it bigger, and we felt like 23 was going to be a size that was going to work, and so that's what we picked.
Herms, anything more aggressive than that?
No, I was thinking 22 to high, and I would try and protect the coronary.
You know, typically we go the same size as the inner diameter of the surgical valve, or +1 there, at least to start with. Do you agree with that, Dave?
Yeah, absolutely.
Because this was a 21, so I'd do a 22.
Because that's what you taught me to do, Steve.
Yeah.
So at Cath, the gradient went from 44 down to 10, believe it or not. And then on the TTE the next day, the mean gradient was 25, and her symptoms were a bit better, but not perfect.
Bob Burke, if I could, Bob Burke, how important a point, I think that's a great point. How important a point is that to, Herms has said it before in our interactive case reviews, that the TTE the next day is really where the money's at in terms of understanding the true hemodynamics in EOA.
Oh, that's absolutely true. The intra-op is important because if the intra-op looks bad, you're going to be in trouble. So you have to address bad news. If it looks good, you don't want to just go and just high five everybody and say everything is done. You really don't know the final story until the following day.
Herms, what might you have expected hemodynamically if you had gone with the core valve? Do you think the core valve is associated with better hemodynamics, or is that uncertain in these sort of very complex cases?
So probably all else being equal, the hemodynamics are better, but the vagaries of measuring these gradients, particularly post-valve and valve, on a balloon expandable versus a self-expanding, it's very complicated. And pressure recovery is probably larger for a balloon expandable than it is the self-expanding. You know, the guys at Beaumont have done great work, as well as Ohio State, actually looking at that. And I'm not all in that, geez, the next day the chest wall echocardiogram tells you all. I think it's you have to integrate what did you get in the cath lab, and then follow it down the line, because this is a very complex discussion. This is an hour discussion.
Okay, so Mike, taking us around third base here. What's next?
So, you know, I think it's really just conclusion. She's done reasonably well since that time back on warfarin for her underlying comorbidities. You know, so clearly she had as much patient prosthetic mismatch as she had valve degeneration. And I think the valve-in-valve solution here was somewhat aspirational. And perhaps the core valve would have been better hemodynamics, but there are difficult trade-offs between coronary access and hemodynamics there. And you know, if I had to do it again, maybe I would have used the core valve. Clearly, Basilica is challenging, and it's not, you know, it's not for most labs in its current form. And definitely, if you've not done some of these, you need a proctor, and you need to budget some time, because this is not just you go in and burn a leaflet. And I think we absolutely should have post-dilated the frame initially. And I think you're right. I think protecting the coronary was probably the right answer, and just post-dilating it without protecting was somewhat cavalier, but we did get away with it.
Michael, what's the learning curve on Basilica? I mean, at what point do you feel like you're off the training wheels with that procedure?
Well, I would defer that to others. Who's done the most? How many have you all done?
Carlos has done a lot.
Yeah. What
do you think, Carlos?
What's the learning curve?
It takes a good 10 cases, to be honest. And that's talking about the left coronary cusp, right? The right coronary cusp is a completely different animal with a completely different set of complexities. So, you know, you're talking about single basilica. When you talk about dual basilica, it takes you from, you know, if you're learning this procedure from a 3-hour to probably to a 5-6 hour procedure.
Plus you picked
when you're learning. So
Mike,
So I agree that if you need a proctor, you should get a proctor if you're in your learning phase.
Mike, I think you picked a really hard valve to do your first case on.
Yes, clearly.
I think he had another choice, though. Yeah.
I know, but I think the externally wrapped valves are the hardest to do. You know, the good ones to start with are a classic Carpentier-Edwards valve. Wouldn't you think, Carlos? Those are probably the best.
Because then you have your posts. When you can see your posts, you can direct yourself angiographically as well, not just echocardiographically. You just line up your posts, line up your catheter to your posts in the middle of it. Find your two best views, which you can achieve that pre-procedurally with CT scan, and then just guide yourself. I can tell you that we've done basilicas, single basilicas, under an hour now.
All right, I'm going to give each one of you 30 seconds each for sort of your parting shots. Yak, we'll go with you first.
First of all, it was a great case. It was great technique. You showed how difficult this can be. You know, the only thing I'll say is that we typically post-dilate all valve and valves. I do that for two reasons. One is to achieve the best gradient possible, and second, to try to make the TAVR valve as, I think it's constrained by the surgical valve, so the post-dilatation helps get it to the correct shape.
Herms?
Agree completely with Steve, as always. This is a fantastic case, Mike. I think it also points out the initial decision about these valve-in-valve patients. This clearly, you know, she was a TAVR, but you know, they're intermediate and low-risk patients like this, and you get these challenges, you know, it's okay to do a reoperation and set them up for their TAVR down the road.
Okay, Carlos.
Pre-procedure planning, nothing like it. You know, you have to know the length of your valve, the diameter, the internal diameter of the valve that you're trying to post-dilate, your VTC, which is valve to coronary distance, and then you plan ahead to either protect or do basilica or both at the same time. I think that's the key and saves a lot of time when you do your pre-procedure planning.
Burke?
Well, I think Carlos pretty much stole my thunder there, because the pre-procedural stuff is really my world. And I think that, you know, he explained exactly why you need to look through this and be very mindful of what you're going to get yourself into and really how you're going to bail yourself out. So, you know, I think the plan was great and it was executed wonderfully.
I think it's a spectacular case, but yeah. I expected no less when I asked Mike to present a case. Mike, you get the final word.
Yeah, I mean, I think this shows, you know, to me, this is brings humility. These things are, you know, this is real world. These cases aren't clean. The decision making is difficult. You know, how hard to push a patient for reoperation. This lady was like, I struggled with my first operation. I'm not having another one. Yeah. And reality, I think you're absolutely right. A good operation would have been the better choice for her. But this is the, you know, she just wasn't going to have it. And then, you know, starting basilica is definitely, there's a learning curve, and hats off to Carlos with his experiences. This is definitely something that takes some time.
Well, this was a fantastic interactive case review session. We thank you for joining us at SIF Virtual. There's a lot more interesting cases to come. This is really our expert TAVR panel. They do such a spectacular job. We thank you very much for joining us, and we look forward to our next SIF Virtual.